EM board bombs.
Welcome back to EM Board Bombs. How you doing, Dr. Briggs?
Excellent. Just happy to be here. Did a nice little run.
Oh,
Ready to record a podcast. I didn't get heat stroke like you did.
Hey, that's messed up. we're not going to go
full
into
recovery.
That. You
full
should
recovery.
listen to one of our prior episodes for that.
Yeah. I think that was like a year ago.
18-mile jog I did. Yeah. Hey, I did not get heat stroke, by the way. Just my calf started cramping up on me. How many miles did you do?
Yeah.
Answer the question. Huh?
Answer the question. Only 3.
Oh, come on. I did 4 miles
I'm a
this
low
morning.
distance.
Come on.
You did what?
4 miles this morning. Come on.
Oh, okay. 1 more mile. I'm so sorry
right.
that I didn't meet your expectations.
Hey, look, at least you aren't dealing with this.
I just noticed that in
the
the
YouTubers
camera.
can see an ulnar gutter splint
What the
on my
heck is going on?
on my hand. I'll tell you.
That looks like a very urban male owner gutter. It's a nice job making it very stylish looking.
So it happens, you turn 40, Briggs. You're far away from that, but things start happening.
Yeah. If Lululemon made a splint, that is your splint right now. It looks like a Lululemon splint.
That's awesome.
Someone go on YouTube and check this thing out. I'm not kidding you.
Oh man. Anyways,
only you would have a stylish splint. I'm sure your wife bought that for you.
Hey, thank you to our sponsor. Remember our one and only sponsor, EM News. They are awesome.
Yes.
We love them. Go to emnews.com, subscribe, sign up. They have great articles. They'll even mail you out stuff so you can just pretend to be smart while you just sit there leafing through their wonderful magazine. And also, EM Rapid Bombs. Go check it out. emrapidbombs.supercast.com, or just go to our website, emboardbombs.com, and you can find our question bank there. Board season is starting to light up. We're starting to see more and more subscribers on EM Rapid Bombs. Remember, that is the podcast that cuts through and just tells you what you need to know. 3 to 5 minute episodes. Boom. We are at almost 500 questions now, which is pretty amazing. And I would say each question has personal coaching that we add in. So it hits not just one question, but multiple questions that you might be presented, which is great. So, Briggs,
You know what's interesting?
Yeah, what else?
You know what I read the other day in EM News?
Yeah, what did you read?
Front page article that board scores are not doing so hot over the past couple of years.
Yeah, I heard about that.
You know what that means?
Yeah.
People need to subscribe to EM Rapid Bombs.
Yeah, EM Rapid Bombs. It's like
seriously,
it's like $149 a year.
Yeah,
talk about
what a great investment.
We're cheaper than Netflix,
versus paying twice for the boards. Yeah, I think that's a no-brainer.
and also when you compare us to other board studying material,
yes.
Somebody reached out to me and they were like, "Is this price right?" I'm like, "Yes, it is.
The price is right.
The price is right." Oh, anyways. All right. We just want as many people as possible to be able to subscribe. It's pretty awesome. It's awesome too.
We want you to pass your boards.
Yeah, we want you to pass your boards. And it's pretty cool. More than 70% of people continue to listen to the podcast, even after boards. I think people realize it's good for just life advice. Going through old episodes like I do is pretty awesome. All right, Briggs, let's get into our question. So it's not as much a question as a scenario. This is actually a true story. This happened to me.
Yes.
You're working an overnight shift when you notice your charge nurse getting the trauma bay ready. She's doing it all by herself. She's actually not doing it with anyone else. You come over. It's been a pretty casual, quiet, that dreaded word, quiet shift. And you ask her what she's doing. Again, this is a true story. She says she's got a text message from one of the police officers she knows about a call that they ran on shots fired, basically. When police showed up to the downtown street, bystanders said someone had been shot and that they just noticed somebody throwing them in a car and they drove off. It was very hazy in general. I looked at my kind of grizzled charge nurse with 30 years of, more than 3 decades of experience. And I'm like, you really think they're going to show up here? What are we doing getting all this stuff ready? She looks at me, and she was like, come on, Hussein. They're about to roll up in here. I didn't think anything of it, went and started seeing other patients. And then all of a sudden, ton of commotion. Security comes running in. There are these 2 guys just naked except for some shorts on. And they're literally just carrying someone with a gunshot wound. Just completely unresponsive. Gunshot wound through the chest is what we'll say. I've changed some of the details here just to just to make it conform to our question, but the scenario did happen. And I was thinking, wow, I cannot believe this is going on right now. And also, I had to give props to my charge nurse. She called it. Hey, Briggs, who has the greatest chance at survival from a resuscitative thoracotomy? Is it A, a penetrating chest trauma? Is it B, blunt chest trauma? Is it C, penetrating abdominal trauma? Or is it D, penetrating thoracoabdominal trauma?
Correct answer here is going to be choice A, penetrating chest trauma.
Okay.
So, hey, we're talking about part 2 from our chest trauma episode from last week. And you know what's wonderful?
Yeah.
Shout out to Jenna Kirby, one of our amazing graduates, fellow alumnus.
Yeah,
I'm not kidding you.
awesome.
I didn't tell you about this until now. Yeah, I wanted to save this text on purpose
to
to lighten your day up. She said, quote, "Yo, listening to chest trauma pod this AM driving in. GSW to the chest, waltz in. Don't worry, I remember the ANSEF."
That's awesome.
And ladies and gentlemen, I did change a few details of that, so it's not the actual. It didn't happen today, but
I got
exciting things. Thank you, Dr. Kirby, for your help with that patient.
She's going to be so pumped about getting a shout out too.
Yeah. She deserves it.
She deserves it. She's awesome.
Yeah. Hey, let's talk about chest trauma. So we talked on last episode about pneumothorax, and now we are not talking about, by the way, let me back up. We are not talking about doing a thoracotomy in the ED. This is not that podcast.
No.
This is a blue-collar podcast. Blue collar. This is not cutting edge, cool trauma stuff.
No.
No, that is not the role of this podcast. But you could get a test question on him, and just like this one.
Yeah.
Simple, knowing the stats, knowing the type of patients that get this done, that's great. We're keeping it really simple here. Last episode, we talked about what are those 3 critical life-threatening injuries you got to identify on a chest trauma patient coming in, either blunt or penetrating. One is, of course, are they breathing or not? Do you need to just intubate them straight up?
Sure.
Number 2 is, do they have a life-threatening pneumothorax you have to manage? And number 3, we hinted at, which is obviously being covered on this podcast, is there any traumatic cardiac tamponade?
Yeah.
And the big thing here is to not be fooled on the initial presentation. The patients can look stable initially, especially young patients. We talked about that last episode. And none of this is going to have any Beck's triad. In fact, Beck's triad for like anything, medical tamponade or cardiac tamponade,
guys, we know,
completely worthless.
We know. Yeah,
we know.
Continue.
Well, the listeners know. Hopefully.
Yeah, especially if you listen to EM Rapid Bombs, we talk about it.
We've talked about it. We've destroyed that. Poor Dr. Beck, if he was a doctor. So, no idea. Why don't you look on that as we're talking?
Yes.
So the only way to diagnose tamponade is ultrasound. That is the only way you're going to know in the trauma bay. So anytime a chest trauma patient comes in, you 100% need to do your initial primary survey and then right away do your FAST, including the subxiphoid view or whatever view you can get that you are looking at the heart. And that is the easiest way to diagnose tamponade. Now, what are you going to do from there? Well, if you're at a trauma center, then you're going to call your trauma surgeon or whatever, emergency general surgeon, whoever you have at your shop. If you are one of the unfortunate heroes working at a rural critical access hospital,
#heroes,
very much a hero, you are on your own. And gosh, if you had a scenario like this, please write us. We'd love to hear about your crazy stories. But in general, you are kind of on your own here to do one of 2 things. And this is where we're going off the ranch. Just a quick word, because I feel like we have to tell our listeners what you're going to do here. One, you're going to obviously arrange transport as fast as possible. 2, if they're unstable, you're going to do your best in terms of maybe doing some type of pericardiocentesis, something temporary as much as possible. That is not the correct definitive answer, but it is what you're doing on your own. Obviously, we don't expect you in a rural critical access hospital to crack open a chest by yourself and a transfer patient an hour away. That's absurd. So you're going to measure your resources, measure what you can do, what you feel comfortable with, and obviously talk to your consultants and try to get the quickest care possible.
Hey, I really want to emphasize something here. This is really important because you can actually have, even in a blunt chest trauma, you can have a cardiac tamponade, right?
Absolutely.
That forms. And the interesting thing here is that you don't need a lot of blood to actually cause tamponade physiology. That is critical to understand. So if you have a patient that comes in and they're just hypotensive. They have no signs of any obvious like injuries. The chest X-ray looks fine.
Right.
And you do a bedside, cardiac ultrasound. You notice like a little bit of an effusion there. And then you do a repeat one, maybe, or aggressively do a repeat one if you still can't figure out what's going on and you notice that effusion growing. That is almost certainly going to be your culprit as well. So have just kind of like a low threshold to be thinking about that when you can't find any other reason for that hypotension. And
Absolutely.
those patients, it's really important what Briggs, what you mentioned about going to the OR if you're able to. Your trauma surgeons will always want to take these folks to the OR. I mean, they're going to be like unstable in the sense that they're going to be hypotensive, but it's much better for them to be in an OR setting to open up and do a much better job than just cracking open a chest, in the ED setting, right? So they prefer to do it in the operating room. Putting in a window is much better to do there than it is, trying to do something in the ER. So cannot emphasize that enough.
Totally. Just a few stats on the thoracotomy. And we're not, again, talking about doing the procedure, something like that. It's just the stats because as a resident, I know this is something that is so rare. You may go your whole career, especially at certain shops, and never see one of these. And that's fine. You don't need to know how to do one of these as an emergency doctor. But it is important to know the stats for the board test because they could ask you a question in terms of just the general, pop epi stuff about, okay, this is when you do one, this is when it's not indicated, etc. In general, the effectiveness varies. If you could have a perfect patient that's getting a thoracotomy, the best outcome possible, the survival is greatest among patients with an isolated stab wound to the heart who show signs of life and presentation. Those patients have actually a very good chance at outcome, depending on what happened to them presentation. It is very rare, almost impossible to survive in a resuscitative thoracotomy that's done in the ED among any blunt trauma patients without any signs of life. So in general, any penetrating trauma to the chest, any signs of life, this should be something your trauma surgeon obviously is the ultimate decision maker on this at your shop, but you're having conversations about that versus blunt trauma. They should be either dying right in front of you in the ED bay to make that decision. So let's do a summary here actually of what to do in a traumatic arrest.
Yeah.
In a blunt trauma arrest patient, and this is what I tell residents at our shop too, or students, this is what we can summarize. Blunt trauma arrest, what are you doing? You're going to secure the airway, obviously. You're going to intubate them immediately if you haven't done so yet. You're doing bilateral finger thoracostomies. And if there's no cardiac tamponade on the ultrasound, you're done, unfortunately. That patient is deceased. If there is tamponade present, you should be communicating with your surgeon immediately about a thoracotomy. Okay? Easy. So blunt trauma arrest, only if they lose vitals in front of you, debatable even if in the EMS bay. And then, of course, any signs of massive head trauma, you're not doing any of this. You're calling that code immediately. You are not doing anything. Notice how we said no CPR in any of this. Penetrating arrest trauma, even more simple. If you have penetrating thoracic trauma arrest, you're going to do secure the airway again, is your job, especially as emergency doctor. Bilateral finger thoracostomies, most likely doing a resuscitative thoracotomy. Again, surgeons can be there with you making that decision. Stab wounds have better outcomes than GSWs. And if you're on the fence, you're looking with the ultrasound at cardiac motion, looking for spontaneous heart activity. That's usually something that the surgeons will use as a ultimate indicator of making that decision. Is any of this testable? Absolutely not. But I feel like this is very applicable to real world information.
That's not, but
patients that come in.
For sure. And I love that kind of real world breakdown. But I want to do a short here on the testable, on how they're going to ask you on a test, right?
Yeah.
So on the test, what scenario on the test are they going to want you to say you should be doing a resuscitative thoracotomy? What is that
Stab
scenario?
wound to the
Bring
chest.
it down. Okay.
Stab wound to the chest is any penetrating chest trauma, but they're going to be even more specific because they don't want you to feel uncomfortable. And it's 100% going to be stab wound to the chest, young patient, like 20 years old.
Right.
They're going to make it as simple as possible.
That you're doing it on, right? Briggs, for blunt traumas, in what scenario would you crack open up the chest?
If there's an effusion.
That's it, right? So if there's no effusion, you are not cracking open the chest.
Correct.
You're not doing a resuscitative thoracotomy.
Correct. Unless they die right in front of you. But on the test, absolutely not.
Yeah, exactly.
It's complicated. And that's why these test questions are not that common. They're probably going to get one, if ever, and it'll be this simple. We're really educating on kind of the real life because especially as a resident, I'm like, when do we do CPR? Do we ever do CPR?
Yeah.
And of course, that answer is no, you never do.
Yeah. Cool.
Cool.
That's
good
pretty
stuff.
much it. Yeah.
No, easy episode.
It was an easy episode. We just had a couple key pearls to drop on that. Hope folks remember. See you next time.